Hi, everyone, and welcome to a really exciting show. For the first time in over 2 decades, there is a new medication treatment approach for poor circulation in the legs known as peripheral artery disease. The groundbreaking STRIDE trial has shown that drugs used to lower blood sugar and for weight loss are also helping to reduce leg cramps caused by lack of blood flowing through the areas in the legs that have been narrowed by plaque buildup. We have the lead investigator on the trial with us today, interventional cardiologist Dr. Marc Bonaca, who is the director of vascular research at the University of Colorado, of course, in Colorado. Before we get to him, let's lay the foundation for the discussion and welcome my co host, Dr. John Phillips, to talk about the medication itself, its current uses, as well as side effects. But of course, give us a few moments because I have to say hello, Dr. Phillips. I heard you had a heck of a day, lots and lots of
Yeah,
cases.
yeah,
You almost didn't even make it. You were saving those piggies.
yeah. We had a couple of leg cases that went a little longer than I anticipated. Got nice results. Again, the mission is to keep the piggies on the foot on the leg, etc. And I had a conversation yesterday with somebody just kind of regarding the notion of as long as they're willing to fight for it, we're going to fight with them. And I'm always happy to help out and really excited to hear from Dr. Bianca because I think this is pretty amazing that we found another use for the GLP-1 agonist, semaglutide, and it looks like it objectively the per, it changes peripheral arterial disease in patients, meaning they're able to walk longer. It increases ABIs, which is our measure for P.A.D. So really excited to get his insight and pick his brain a little bit because just reading the trial, I've got a lot of questions, and I'm really stoked for this interview.
So I don't think we should wait any longer. Let's just kick things off with a moment of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
This isn't super like sexy, but I was trying to find something along the lines of like medical breakthroughs because, as you alluded to, it's been probably 25 years or so since we've had a drug that can help people with peripheral arterial disease. And this is just a quote from George W. Bush regarding medical breakthroughs. And he says, we're a caring nation and our values should also guide us on how we harness the gifts of science. New medical breakthroughs bring the hope of cures for terrible diseases and treatments that improve the lives of millions. And I think when you look at it, there are 230 million people worldwide that have peripheral arterial disease. And if we now have a tool that we've known a lot about for other treatment options that can really help people. And this becomes now a vascular medication that hopefully can help patients with PAD and type 2 diabetes.
And that's what I'm curious about in regards to these medications. The next step to say, is this going to be a part of the next generation of PAD management guidelines that come out? I know we just had the 2024 guidelines come out, and it'll take a few years before a new set of guidelines come out. But will this be something that is going to be prescribed as frontline treatment, as part of conservative treatment, especially for those patients that are considered intermittent claudicants in the earlier stages of peripheral artery disease, to see if that works before they go into interventions?
Indeed, and we know that the GLP-1 agonists work on a number of levels. They increase satiety, so they work in the brain. They cause the release of certain cells in the small intestine that kind of help slow gastric emptying, so it makes you feel more full. It reduces blood glucose levels. There's anti-inflammatory components to it. I mean, we know that taking the GLP-1s reduce cardiovascular events in patients with PAD, but now we know, at least based on what almost 800 patients, that it will improve walking distance, improve your ABI, so that's the measure of level of or the amount of kind of PAD that you have. It also reduced what they, I think, termed rescue treatment, meaning like intervention and all-cause mortality in half. So it's pretty amazing. The medicine itself has to be titrated, and they used a dose that's kind of middle of the road. And there were some GI side effects as well, but cost is an issue. And, I think we just kind of have to work our way through this and figure out what are the best next steps for our patients.
Can we just, for those that are not diabetic or not familiar with these semaglutide drugs, the GLP-1s, the ones in particular that they tested, wegovy, rybelsus, I think that's how you pronounce it, and the famous one, Ozempic. Can you go through those? What is a semaglutide drug and how does it work?
Yeah, I mean, so semaglutide is a GLP-1 agonist. So GLP-1 is a peptide that is released in the L cells of the small intestine. There's also something called GIP, which is released in the K cells of the small intestine. That is the combination. So there's the medicine called tirzepatide. Tirzepatide has both the GLP-1 and the GIP, which is why, at least from a weight loss standpoint, you see more weight loss reduction in patients who are on tirzepatide as opposed to the GLP-1. But as I had mentioned, it's released in the small intestine. It affects glucagon levels in the pancreas, so it lowers glucagon levels. Glucagon increases blood glucose levels. It also affects satiety, so you feel hungry. It slows, or you feel full quicker. You eat less. It also reduces alcohol consumption. There's also some thought that it might reduce how people take in or how people smoke. So that might have some benefit with the P.A.D population. But at the end of the day, it kind of tells you to stop eating. It reduces blood glucose levels, thus allowing you to lose the weight. But there's also these other kind of we would call pleiotropic effects of the anti-inflammation, and I think I've read something that it might be neuroprotective, so helps people with neurodegenerative disorders, potentially like Parkinson's, Alzheimer's. I mean, there's all sorts of things that are speculated that the GLP-1s do. So semaglutide is kind of the generic GLP-1, and these other ones have commercial names like Ozempic.
But there are a lot of side effects you were mentioning. Can you go through some of those? And I'm sure that you've had a few patients coming in and saying, oh my gosh, I can't deal with some of these side effects, because I see the complaints all the time on our social network.
Well, again, I don't prescribe the medication, but I know a lot of people that are on it. Because it causes early satiety and decreases gastric emptying, people kind of need to understand that you have to eat less. And so your brain's telling you not to eat as much as you normally would eat. And so sometimes people can have GI upset and bloating, a little nausea. In severe cases, you can have issues with the pancreatitis and the pancreas getting pretty angry. But that's why the dose is titrated, in the sense that the patients in this trial, I believe, were on one milligram, but you usually start somebody on like 0.25 milligrams for a week, and then you go to 0.5 and maybe 0.75, and then you go to the 1 milligram. I think the max is about 1.5 milligrams. It's injected using a little tiny insulin needle weekly. So again, most people can kind of get over it, and there are some people, and this is just anecdotally that I talked to, that they use this term called food chatter in their brain, like it's telling them they want to eat, and these medicines really kind of quiets that food chatter, and that's why people will pay exorbitant amount of money for these medications, because it tells their brain to stop eating. It's helped them. They feel better. I've heard some people report that they just feel like they have less inflammation, and I don't know how you gauge that objectively, but it's pretty impressive what this medication can do.
And coming up next, right here on the Heart of Innovation, we're going to hear more of what this medication can do to help those wretched leg cramps for people suffering from peripheral artery disease. So stay with us. You don't want to miss this episode, and more on the STRIDE trial, a groundbreaking new trial to help patients with peripheral artery disease.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're
underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for. Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Hi, everyone, and welcome back to the show. Semaglutide drugs, according to the new STRIDE trial, significantly improve walking ability and quality of life for those suffering from P.A.D. So let's bring in Dr. Marc Bonaca, Director of Vascular Research at the University of Colorado and lead investigator on this trial, to learn more. Thank you so much for joining us, Dr. Bonaca. We really appreciate you taking the time.
Thank you for having me.
So first, how were you and others tipped off that these diabetes and weight loss drugs, Ozempic, Wegovy, and rybelsus, had this additional bonus for patients who also are suffering from P.A.D.?
Great question. We've learned a lot about these drugs, and a lot of people may know about them because of weight loss, but there are actually a number of effects in terms of, how the body responds to them, cardiometabolic effects. So how we metabolize glucose. And actually, one of the effects is a really potent anti-inflammatory effect. So when you measure a blood marker called CRP, reduces that by, 40, 50%. And, because of that, we were hopeful that by altering multiple sort of things that happen in the body, glucose handling, cardiometabolic risk, weight loss, reducing inflammation, improving blood pressure, all those things together, that we could improve the vascular health of our patients.
Marc, welcome to the show. I can't wait to ask you I've got a lot of questions regarding the study, because this is super exciting. Because when you look at it, those of us that take care of people with vascular disease, it's been almost 30 years since we've had something like Letol, which half my patients don't even tolerate, and has other adverse effects. So now we actually have something that could potentially that helps reduce pain. There's objective information now saying that their walking distance got better, their ABIs got better. So this is now maybe a vascular drug too?
Yeah, and I firmly believe it is, because, what we learned from this study is that the effects were really independent of weight loss or the other effects. And they, just like you said, the sort of blood pressure hemodynamic measure of sort of the perfusion of the legs got better. We've never seen that with the drug before. So I really do believe these are vascular drugs. And actually, in the same meeting where we presented this trial, there was another 9,000 patient trial that showed that it reduced the risk of things like amputation and chronic limb-threatening ischemia and acute limb ischemia. So I think this is clearly a vascular drug. This is not that people walk better because they lost weight. It's because their vasculature got healthier.
That's amazing. I'm wondering, because I work with some of these patients that they, when your glucose is really high, your blood is very thick and syrupy and thick. And I'm wondering if it's also just part of it that the blood becomes much thinner and it's more amenable to getting through some of these narrowed areas, if that could be part of the improvement that you're seeing in these patients.
Well, it's a great question. So the glucose definitely went down. You have very good point. So the hemoglobin A1C, the blood test we use to kind of measure blood sugar control, got better in patients who took the semaglutide by about 1%. That being said, they were really well-treated patients. If you look at the background therapy and the blood glucose levels, they were pretty good overall. And so, if I saw a patient population like this, I'd say, their diabetes well treated, their cholesterol levels of bad cholesterol was 69. They were on all the drugs they're supposed to be, and the improvement in glucose was part of it, but it was pretty modest. It didn't explain the magnitude of effect we saw. So I think that's part of the story, like you said, but it's not the whole story.
So Marc, could you go into the trial design a little bit for us? So my understanding is there were about 800 patients, and after you screened them out and basically divided them out to get the semaglutide at the 1 milligram or not. So normally, if I'm correct, you start the semaglutide at 0.25 and you kind of titrate yourself up. Were these folks titrated up, or did you start them at 1 and like watch them for 52 weeks, and then you look for these objective changes?
Yeah, they were titrated up. So it's exactly like you said, 800 patients, and they were randomized. So we didn't know who was getting the drug and who was getting a matching placebo. And I think that's a really important part because when you ask people how they feel and other things, if you know that you're getting an active drug versus nothing, that might influence what you report. But here we had a matching placebo. Everyone was titrated up the same way to 1 milligram subcutaneously per week. And then they were treated for 52 weeks. And then we saw them pretty frequently, made sure they were doing okay. And then we had a baseline at 6 months at the end of the trial. And then actually 5 weeks after the last dose of treatment, we did really rigorous testing on treadmills, ankle brachial index, a bunch of measures to understand, how they were doing.
In your report, you also mentioned you had a little trouble in the beginning trying to get patients. Why were you having trouble? You mentioned something about there were too many patients getting early interventions, but were you going after the wrong pool of patients in the wrong place? Or what seemed to be the issue that led to your struggle?
Yeah, so in order to really understand, well, I guess there are two things. One, for patients with PAD, we really need to treat them earlier in the course of disease. We shouldn't be waiting for people that sort of about to have an amputation. So we wanted to find people with what we called early stage PAD to try to modify the course of disease or prevent progression. But part of that is that they were symptoms. They had to have symptoms. And, in various places, there's a lot of procedure. There's a lot of revascularization procedures for people who have symptoms. And you can't have that during a study like this because you can't measure the effect of the drug if somebody does a bypass surgery or something else like that. It interferes with the test. So we wanted early stage PAD. The other part of it was that we started recruitment in October of 2020, which, if you remember, is the sort of middle of the early part of the pandemic. And this was a trial you couldn't do remotely. We had to have people come into centers. These were medical grade treadmills, calibrated treadmills, a very high quality study, but you have to come in and run on a treadmill or walk on a treadmill. And during the pandemic, not a lot of folks were, eager to do that. So we got there. It was just we had to work hard to find the right population. And I mean, I think we worked really hard to do a high quality study, which sometimes takes longer than to just sort of enroll anybody, but it really does allow you to answer the question.
Coming up right here on the Heart of Innovation, we'll have more with Dr. Marc Bonaca on the STRIDE trial, a groundbreaking trial, bringing us a potential game-changing drug for people with peripheral artery disease for the first time in more than 2 decades. So you don't want to miss the rest of the story. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane. The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back, everybody. Thanks for joining us. It is a privilege to have Dr. Marc Bonaca on the show. We are talking about the STRIDE trial and the use of semaglutide to actually improve patients with peripheral arterial disease. So it's interesting, right? Because we approach the semaglutides as, well, you have diabetes. It will help you lose weight, help you get your blood sugar under control, also reduce cardiovascular events. But now it makes you feel better. That's an easy sell, Mark, isn't it?
That's a really great point. We work so hard in prevention to treat things like blood pressure and lower cholesterol, but they're hard because they don't make people feel better. Here we have a drug that, prevents heart attack, prevents stroke, other things like that, but it actually made people have less pain when they walk and made them walk further, and it improved their quality of life using two really rigorous quality of life measures that are validated. And so, I think at the base, when we look for novel therapies, we want to know, does it improve function? Does it make people feel better or live longer? The answer is yes to all three of those for this drug, which is really rare.
And what's incredible is I would imagine that your struggle with getting patients in the trial is just indicative of the current state of affairs, where people are not getting diagnosed early on before they develop these symptoms. And especially for diabetics, a lot of these diabetics don't even develop symptoms until they're basically a toe step away from amputation. A lot of times it's wounds that won't heal that become the first indication that, whoa, there might be a circulation problem. Do you think that having a drug like this available will inspire primary care and endocrinologists to start being a little bit more assertive in diagnosing these patients sooner versus later?
What a great comment. I mean, I think that may be one of the key take homes. I think out there's a lot of people who think, well, why bother testing? Because what are you going to do about it? And are people just going to get procedures? And we don't find people out there with P.A.D, but we know that if you look at people over the age of 55 with diabetes or a history of smoking, or over 75, 1 in 3 have P.A.D. And so everyone that's listening to this knows somebody who has it, right? But we're not diagnosing it. I think having an effective therapy that makes people feel better, makes people live longer, that improves their function, hopefully will be an incentive for people to look and say, well, maybe you're not walking so well. It's not just that you're getting older, but maybe there's a blockage in your leg artery, or maybe it's not just your arthritis or something else. Maybe we should test. And it's, a very easy and inexpensive thing to test for.
And do you think that, with these drugs being out there on the market for diabetics, that now they may end up becoming prescribed for patients that do not have diabetes, do not have weight loss issues? Will it be available, do you think, for people that are thinner, that are more fit? Or do you think that it'll be something that's not right for them because they might end up losing too much weight?
Yeah, we didn't see it. It's a really great question. STRIDE, about 30 to 40% of the patients had a normal body mass index, and they didn't lose too much weight. They got the same benefit. Right now you could prescribe one of these drugs for patients who have diabetes, they have obesity, and if they have cardiovascular disease and a body mass index above 27. There was a trial called SELECT that showed there was a benefit there. So, and now I'm hopeful that this might be another indication for the drug, peripheral artery disease. I would certainly hope that, that becomes an indication. Now, there is a group of patients that have peripheral artery disease, a BMI less than 27, don't have diabetes, that wouldn't really be sort of on label right now. Might some clinicians try it? Well, they might. I mean, it would be an off-label use of the drug. I think that we need a trial to tell us, is the benefit the same? I really believe it would be, but that's why we do, research.
So moving forward, do you think that folks will need to be on this the rest of their life? And if so, because a lot of people that are on semaglutide for weight loss or some of the other benefits, they'll kind of get a dose titrated. They'll lose the 12% or 17% with tirzepatide of their body weight, and then they wean themselves and they stay on a maintenance dose. Do you think folks will be on maintenance dose or the 1 milligram, or do you just stop it and restart it every once in a while? What do you think?
Yeah, it's a great question. It may not be the same for everyone. I mean, two observations. One, when we look at the benefit of semaglutide versus placebo, we stopped at a year because we had enough information, but the curves continue to diverge. And so I really do think we were modifying the disease. The second thing is that people stopped treatment at 52 weeks, and we tested them again at 57 weeks, and the benefit was the same. So, I think that there probably are long-term reasons to stay on treatment, maybe at a maintenance dose. But I think even if you can't or you choose not to, that there may be a sustained benefit.
Yeah. So, what do you think in terms of the next steps for this, for these doctors? Do you think, what's the feedback that you've gotten from people that, oh my gosh, I'm going to use this for all of my patients? And of course, you said it's off label, but they doctors, if they think it's right and you have a major study such as this to support it,
Yeah.
do you see that happening? Is that the feedback that you're getting? Hey, I'm doing this. This is great.
Yeah, well, I think that there is a large group of patients who can get this right now on label. If they have diabetes, they have P.A.D. and a BMI over 27, or they're obese, they can get these drugs right now on label. And so I think, the receipt of the data has been really overwhelming. I mean, people are like, wow, we finally have something. I mean, this was stated at the beginning of, it's been 25 years since we had an effective therapy. We never had one that makes people live longer, feel better, and function better. So I do think there's going to be broad use. I expect there probably will be even some off-label use in those that don't have diabetes and a high BMI. And I understand that. I mean, this is a really difficult thing to treat, and we're always looking for new ways to treat our patients.
And coming up next, right here on the Heart of Innovation, we do have some patients that have a few questions for Dr. Bonaca, so we'll get to those in just a moment. Don't go away, right here on the Heart of Innovation on KDOW. Stay with us.
One of the cases that changed me was a young man. He was about, I think, in his sort of mid-40s, late 40s, early 50s, who was a smoker. And he has smoked since he was 6 years old. And he smoked for a good 45 years of his life. And he had, really severe claudication. Started developing rest pain as well. And I had an honest to goodness conversation with him to say, listen, there are people who smoke till they're 80 or 90 and nothing happens to them. You are not one of those people. You are one of these people that if you do nothing, your leg is already struggling. And there's a good chance within the next 5 years, you will lose your leg. Although statistics say there's a 30% chance you will lose your leg within the next 12 months. I then said to him, your choice is simple. Cigarettes or your leg. You cannot have both. That man has smoked for over 40 years of his life. And that day, he actually took the cigarettes out of his pocket and crushed them up and put them in the bin. He goes, doctor, today, you're the first person who has spoken to me in that way and told me the reality and of what this actually, what this actually does. He actually stopped smoking. We managed to do an angioplasty on him, got him out of rest pain. He then got a dog, started walking the dog, completely turned his life around. And I saw him a couple of months later, and he felt so much better. He was richer. He had loads more money. He was walking more with his dog. He's playing more with his kids, and he just felt his life was a lot better. And I think, for me, one of the powers that we have as a surgeon is when you give somebody lifestyle advice as a surgeon, some people take it a lot better than if, say, a podiatrist says it or their family says it or somebody else says it. Sometimes something from a doctor just carries a bit more weight. You're saying the right thing to the right person at the right time. And I think for me, it was just that conversation that just brought the reality home to him, and he completely changed his life. And I think that when I saw him again, I was like, yeah, that was good.
Welcome back, everybody. Thanks for joining us. Marc, I've got a question, kind of nerded out a little bit, and as I imagine you are, like, what exactly is going on? And I know the anti-inflammatory component of it, but is there some lesion-specific benefit? So perhaps a blockage in above the growing versus below the growing or below the knee. Do we know that having a blockage one place or another, there might be a better benefit with the medication?
Great question. What we saw was that the benefit was consistent no matter where the lesions were or the blockages were. Your question about mechanism is spot on. And so when you look at patients with PAD, there is an inflammatory component. You see inflammation around the vessels, and that can even lead to some constriction of the vessels or limitation of flow. And there was a coronary study with semaglutide showing that there were changes in that adipose and inflammation around the vessels. Now, we didn't do that in this study, but I think that might be a next step in understanding mechanism, is looking at the effects of this class of drug on the inflammation around the vessels and whether that's why the blood flow is getting better.
Okay, I want to get to a couple of questions really quick because they are burning for some patients. And so I want to jump to Marcia O. Marcia O, go ahead and unmute and ask Dr. Bonaca your question.
I wanted to ask if other drugs, and I don't know that much about drugs, could work the same way that aren't the three that you've talked about. And one of them is Adipex or phentermine, because I was on it for a very, very short time and I could walk like crazy, but it was a pill form and it was a low dose.
Great question. I don't know. I mean, phentermine is a really different mechanism from what we studied. So I wouldn't necessarily take the results of STRIDE and broaden it to something like phentermine. But I think what you said is really intriguing, and I wonder whether it could have some of the same anti-inflammatory or cardiometabolic benefits. I think we need to study to know. But thank you for sharing that. I think a great opportunity.
Susan, do you want to go ahead and unmute and ask the doctor your question as well?
Yes, I was on it for 1 month. And I guess it was like the generic version, because I got it online, and I've never felt better. But when I tried to find a doctor to prescribe it, I can't find a doctor that will, except for Wegovy, which even with insurance, it cost me $800, which I can't afford.
Yeah, see, this is an issue with so many patients. How are we going to handle, especially if this is such a breakthrough for these patients with PAD? We have the most vulnerable populations that can't afford these GLP-1 drugs. Any talk on what we can do here? Because now everyone's excited about it, but if people can't get their hands on it because of the cost, that's a problem.
Yeah, coverage is very different depending on the indication. So coverage for weight loss is much more difficult than coverage for diabetes or coverage for vascular disease. I'm hopeful that, this data will help change the coverage for this indication for patients with PAD. That being said, it's still going to be too expensive for a lot of people, but I am encouraged. There's so much development. I think there's going to be multiple agents on the market in the next few years, including oral versions, injectable versions, and hopefully we'll be able to have a solution that most people can access.
And we're going to go to Donna. Donna, go ahead and unmute and ask the doctor your question.
My question was around the tirzepatide. Is it possible that those same results could be seen with the tirzepatide?
Yeah, it's possible. It certainly is possible. It's something that, hoping that we can study in a future trial. Right now, I'd probably try to get the drug that was in the study. If you can't, in tirzepatide is what you're on, then it's hopefully it has some of the same effects.
Marcia just has a question.
Hi, doctor. I'm not diabetic. I have critical limb threatening ischemia. I just had a toe amputation and I'm skinny. I'm too skinny. So I'm wondering what effect the drug might have on a person like me who's skinny and doesn't have diabetes.
It's a great question, and I'm sorry for all you're going through. I know, chronic limb threatening ischemia is a really, really tough problem. I have a lot of patients who have that. I believe from the data that we saw in STRIDE that the effect is independent of weight loss. And in fact, in the trial, patients who had, lower BMIs or body weights had the same benefit, but all of the patients did have diabetes. And so I do think that, there's the great potential that it would work in someone like you too, but we need a trial to prove it, because even if it's independent of weight loss, all the patients in the studies had diabetes. So I think that's going to be the focus of future work, and hopefully will be done quickly so that we can expand access to this type of therapy to people like you if it does show the same benefit.
So, Mark, is this stuff going to be in the water?
Yeah, great question. There are so many benefits. I do think that this is a game changer. This class of drugs, game changer. I mean, it makes sleep apnea better, right? Makes your kidney function better, reduces heart attacks and strokes, make people feel better. So I think it's a game changer. But, one of the people had asked about tirzepatide, another drug in this class. It works on two receptors, not just one. We're going to really have to learn about which agents have which effects. I think the good news is there's so much development. People are developing oral drugs, long-acting drugs, short-acting drugs, that's going to bring price down and make these more available. I think over the next, years, we're going to see that these are going to be broadly available and in a way that, people can take them.
Is it going to be available, do you think, globally? Is this something that you're seeing everyone excited about worldwide right now?
Yes, it is. I mean, I think that these drugs are available in many, many countries. There are many countries that have the same indications as we have in the United States. So I do think that the impact of the trial will be global. Yet, there are a lot of parts of the world where people really struggle to get access to, very basic medications where they're not going to be available yet. And again, this is where I think we all need to work together to expand access and come up with novel ways of this, of affecting this treatment target. A long while ago, statins weren't, available to everybody globally. Now they are. And so I think these drugs will get there, but it's going to take some time.
Yeah, and coming up right here on the Heart of Innovation, we're going to have the final takeaways from Dr. Bonaca and, of course, final thoughts from Dr. Phillips. So stay with us for our Spur of Innovation segment. That's next right here on the Heart of Innovation and KDOW. We know that walking, if we walk at a brisk pace, it has the cardiovascular benefits, right? It's great for your heart. It's also great because your calf muscle is like your second heart. And with every step you take, it's helping with the veins. It's helping that blood flow back to the heart because your muscle there in the calf is contracting and pushing that back. But what most people don't really know about are the collateral vessels that can develop when the arteries, you have your human superhighway, the arteries send blood flow south, the veins back north, but these arteries that send blood south can get all mucked up, just as in your heart, with lots of plaque, all the fats, the cholesterol, even clots, all of the above. But when you get blocked up, your body actually responds and says, whoa, we need some detours, right, Dr. John?
Yeah, so it's kind of interesting. Like in the heart, for example, people that survive a massive heart attack have often developed. So they'll have an underlying blockage that, maybe it's like, I don't know, 50%. And when the heart attack occurs, it blocks 100%. And that's, obviously a life-threatening issue. But as the progression from that 50 to 100 or whatever it is, some people have the ability in the heart to develop or have these collaterals that are kind of pre-existing, or they've started to kind of develop through a term called arteriogenesis that we'll get into, and that's a lifesaver for people, like literally. It's those folks that are running and just drop dead from a heart attack that don't have these collaterals. In the P.A.D. world, collaterals are huge in the sense that they're kind of like that bypass, nature's bypass, that way to offload that blockage and help people continue to keep the leg perfused, getting good blood flow, and then ultimately just adapt to that blockage and further, kind of allow them to walk or function at a pace that they may not have been able to do so prior to. But again, it's all about conditioning. It's conditioning the muscles and conditioning the arteries, so to speak.
Hi, everyone. Welcome back. Ozempic, Wegovy, and rybelsus, known as semaglutide drugs used for diabetes and for weight loss, have a significant effect on improving leg cramps in patients with poor circulation, known as P.A.D. The STRIDE trial just released shows patients taking these drugs had a 40-meter improvement in walking distance. They experienced a significant quality of life benefit and a 54% reduction in disease progression requiring intervention. Huge benefits from these drugs, and we're excited to see what more they could have for patients going forward. But this could be life-changing for millions who struggle with leg pain, with peripheral artery disease. So let's get the key takeaways on this study from lead investigator Dr. Marc Bonaca, followed by Dr. John Phillips' thoughts on how this will impact his patients as well. Dr. Bonaca?
Thank you. I thought you summarized it really well. It's the first time we've ever had a drug that makes people feel better, function better, and live longer. These is also a class of drug that improves kidney outcomes, sleep apnea, reduces heart attack and stroke. And so I do think this is a vascular drug that modifies the course of disease. And I hope it just opens the door to a new era of better therapies for people suffering from P.A.D.
I echo those sentiments. I think this is where the rubber meets the road, and we have to persevere and push the insurance companies to approve this, because I fear that, I can write the script, and if there's a pre-auth and all this inertia, then it kind of gets lost, and we really have to fight for our patients and do this. And then the other thing I'll say is that, some people might poo-poo 40 meters, but that's a lot for someone who I think at baseline they were at 180 or so. And if you look at people with heart failure, symptomatic heart failure, if they get an extra like 20 meters, they're ecstatic. So again, game changer, probably will affect the guidelines, I would imagine. And now we just have to get it to our patients and get them feeling better and living longer.
And from both of you, we know that interventions and surgical solutions to P.A.D. and poor circulation, they're not durable. So do you see this as potentially being that ultimate holy grail for these patients, something that's durable for the long term with a huge impact?
Yeah, it's a great question. We observed, somewhere between 8 and 9% of the patients during the 1 year that we followed them progressed to needing, procedure or having a bad outcome for the limb or actually dying. And we saw a 54% reduction in that progression. I have a lot of respect for my interventional and surgical colleagues. They do great work, but as you said, there are limits to those interventions and a lot of risks afterwards. I'm very hopeful over the long term this could really reduce the rate of progression and the need for those procedures, and I think that could be a game changer here.
And I love doing procedures as much as the next person, but you're right, the durability is questionable. I hope that we can figure out maybe certain biomarkers that put people at risk in their 20s and 30s, get them on some of these agents. So yeah, it might put me out of a job, but you're saving lives and preventing P.A.D. and cardiovascular events.
On that note, thank you everyone for joining us. Congratulations to you, Dr. Marc Bonaca, and your entire team of investigators and all of the patients that were involved in this study. We thank them as well for their participation in such groundbreaking research. Thank you for everyone for joining us. We really appreciate you. I hope you have a great weekend.
Your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAD, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link for circulation and pain. Left untreated, your leg might